Good morning, everyone. Thank you for joining us for this first event of Liver Cancer Awareness Month. We've titled it United Against Liver Cancer. I'm Fiona Beck. I'm part of the DICE team for Digestive Cancers Europe, and I'll be your moderator today. While everyone gets settled, can I remind you firstly that this event will be recorded? And secondly, that there'll be an opportunity to ask questions at the very end. If you've got some questions, you can submit them throughout the entire webinar. You'll see there's a box and labeled Q&A with a picture of a question mark, which you can click on and type your question to submit. To give you a full welcome and also set the scene for liver cancer in Europe, I would like to present to you now Zorana Maravic, who is the CEO of DICE. Thank you, Zorana.
Thank you, Fiona. Good morning, everyone, and welcome. This event is jointly organized by the International Liver Cancer Association, the European Association for the Study of the Liver, the European Liver Patient Association, and the International Liver Cancer Movement, as well as Digestive Cancers Europe. We have titled today's event United Against Liver Cancer, because we believe a united effort is essential to reduce the devastating impact of liver cancer both in Europe and globally. Our organizations have been collaborating closely for the past 2 years, and today we are here to raise awareness and push for immediate coordinated action. In 2020, around 87,000 Europeans were diagnosed with liver cancer, and about 78,000 have already died from the disease. Sadly, these numbers are likely higher in 2024, as liver cancer mortality in the EU increased by 70% between 1990 and 2019. Globally, without effective prevention, liver cancer incidence is projected to rise by 55% from 2020 to 2040. And despite these alarming figures, public awareness remains low with serious consequences. Firstly, this lack of awareness hampers preventive programs. The importance of hepatitis B vaccination, hepatitis C treatment, and addressing non-viral risk factors like alcohol-related and metabolic liver disease cannot be overstated. Preventive strategies together targeting alcohol consumption, obesity, and risk education are urgently needed. Secondly, late diagnosis remain a critical issue, with over half of patients diagnosed at advanced stages. Early diagnosis improves survival, and regular ultrasound surveillance is recommended for patients with cirrhosis, who account for 90% of liver cancer cases. However, only 20% of these patients currently receive semi-annual screening, a gap the EU and the European countries should urgently address. And lastly, patients at risk for or diagnosed with liver cancer often face stigma, both socially and within healthcare setting, which worsens outcomes. It is vital that we work together to raise awareness and urge policymakers to prioritize liver cancer. Today's webinar marks the start of Liver Cancer Awareness Month and launches a collaborative campaign. You will hear about the current situation in Europe, political endorsements of the EU Cancer Plan, prevention strategies, early diagnosis, and global and European advocacy efforts. Together, we can tackle the growing burden of liver cancer and improve lives. Thank you, and over to you, Fiona.
Thank you, Zorana, for this overview of the impact of liver cancer in Europe. I'm now pleased to welcome Amit Singhal. Dr. Singhal is a professor of medicine at the University of Texas Southwestern Medical Center in the USA. He serves as chief of hepatology and medical director of the liver tumor program. In fact, he's joining us today from a US time zone in the middle of his night, so we extend a special thanks for this commitment. With over 300 peer-reviewed original publications, Professor Singhal has been awarded the Willis Madry Distinguished Chair in Liver Disease and the Blue Fairy Award for Excellence in Liver Cancer Research. Today, he'll speak on early diagnosis and screening. Over to you, Dr. Singhal.
Thanks, Fiona. Quite an honor to be here. As you heard about, liver cancer is one that we see an increasing mortality and one that we clearly need to do better. We've heard about the importance of prevention and as well as the importance of screening and early detection. And so I've been asked to speak for the next about 10 minutes on early diagnosis of hepatocellular carcinoma and what we mean by screening and the importance of screening. Here you can see my disclosures. So to start, as an overview, here we can see a copy of the Barcelona Clinic liver cancer staging system. I'm not going to go through the details of this staging system, but I show you this to simply show that patients can present with a wide range of tumor stages. On the left-hand side, we can see early stage diagnosis, and as one progresses to the right side of the slide, you can see patients who would be classified as intermediate, advanced, or terminal stages. And this is related to a combination of the amount of cancer they have, their liver dysfunction, and their performance status, i.e., how strong they are at the time of diagnosis. I show you this because one of the strongest drivers of prognosis is early stage tumor detection. If we find patients at an early stage, we have curative therapies available, including local ablation, surgical resection, liver transplantation, and these therapies are associated with survival well over 5 years, if not well over 10 years. We see the prognosis drops off once patients are diagnosed beyond an early stage, with survival typically between 2 to 3 years if one is found with larger tumor burden or worse liver function, really underscoring the importance, once again, of early detection so we can deliver these curative therapies and offer the best survival for our patients with hepatocellular carcinoma. When one takes a look at the typical cascade of how one can develop HCC, here we can see a simple schematic of how this happens. Most HCC, as we've heard about, develops in the setting of chronic liver disease, if not in the setting of cirrhosis. So one can see at the bottom, one starts with a normal liver. One can develop chronic hepatitis from any one of several different etiologies, whether those are viral in nature, like hepatitis B and hepatitis C being the most common, or non-viral etiology, whether that is alcohol-related or what we now call metabolic dysfunction-associated liver disease, i.e. chronic liver disease that happens in the setting of obesity, diabetes, and the metabolic syndrome. As one has chronic hepatitis for extended periods of time, one can develop cirrhosis, that is scar tissue laid down in the liver related to this chronic inflammation and damage. And once somebody develops cirrhosis, they have an annual risk of developing hepatocellular carcinoma of 1 to 3% every year. So this really is one of our biggest target populations, patients with cirrhosis. Now, there are a couple etiologies that can bypass this step of cirrhosis and go directly to HCC from underlying chronic hepatitis. Historically, the most common cause that happened within was hepatitis B, but we are now seeing this more and more with metabolic dysfunction-associated liver disease. And so we now see on the left-hand side of your slide, if you take a look at the bars and you take a look at the portion in green or red, you can see those portions of HCC that happen in the absence of cirrhosis. And once again, we can see that this can happen in hepatitis B, but what we're realizing is that one of the most common causes this happens in is those patients with metabolic dysfunction-associated liver disease. Up to 1/4 or 1/3 of patients can develop HCC in the absence of cirrhosis. And this is important because it informs which patients should undergo screening for early detection. Now, this really caused a lot of alarm because of the large number of patients who have metabolic dysfunction and the ability of health systems to effectively offer screening to that large at-risk population. What we have started to realize is that the risk of HCC does appear to be highest in those patients with cirrhosis, and those patients without cirrhosis have a very low risk of developing HCC on an individual patient basis. But when one takes a look at the large denominator of at-risk patients, that's really why we have such a large number of non-cirrhotic HCC in the setting of metabolic dysfunction. All of this being said, the reason why I show you this is because this remains an important issue in our screening delivery. And one of the things that we're going to have to really do is to find ways to identify those high-risk non-cirrhotic patients in whom to do HCC screening. Short of those data, what we have here on this slide is a table for those patients who typically right now should undergo screening. And in brief, what we see is that these patients are those with cirrhosis from any etiology, whether once again that's viral, hepatitis B or hepatitis C, or non-viral, alcohol, metabolic dysfunction-associated liver disease, or one of several genetic / sort of inherited conditions that one can develop cirrhosis from. Patients that are at high risk with non-cirrhotic chronic hepatitis B, whether that's defined by demographics or risk stratification scores like the PAGE-B score, also should undergo HCC screening. At this time, current guidelines from the EASL as well as AASLD do identify patients with non-cirrhotic metabolic dysfunction liver disease as a category that we don't have good data in how to deliver HCC screening at this time. When one takes a look at why we should do HCC screening, we know that there was a large randomized clinical trial for patients with chronic hepatitis B that was conducted in China many years ago. And we see in this randomized trial, those patients who received HCC screening were significantly more likely to be diagnosed at an early stage. You can see that in the table, 60% versus 0%. Significantly more likely to undergo curative therapy, 47% versus 8%. And most notably, HCC screening significantly improved survival. It reduced the chance of dying from liver cancer by 37%. We also have good data in patients with cirrhosis. So here we can see results from a systematic review and meta-analysis, i.e. a summary of the literature over the last 10 years. And in brief, what we see is that HCC screening was associated with improved clinical outcomes in patients with cirrhosis. Nearly 2 times higher odds of finding cancer at an early stage, nearly 2 times higher receipt of curative therapy, and once again, a 33% reduction in the risk of dying from liver cancer. So this process of HCC screening, both in chronic hepatitis B as well as in cirrhosis, has been endorsed by both by professional society guidelines, including those of EASL and the AASLD. Now, how do we perform screening? Screening is typically recommended using a simple abdominal ultrasound, the same test that we use when taking a look at fetuses during pregnancy, so very safe, very easy to receive in terms of being widely available and relatively cheap. So this abdominal ultrasound is combined with a blood test called alpha-fetoprotein. And what we see is that by using the 2 tests in combination, we can find the vast majority, about 65%, if not higher, of HCCs at an early stage. And so this is currently the strategy that is recommended by, once again, professional society guidelines in terms of being widely available, cheap, and simple to do, and safe. Now, one of the things that's important is that if one is to have either test being abnormal, whether that be a new abdominal, like a new liver lesion seen on ultrasound, or an elevated alpha-fetoprotein, that blood test, if either is elevated, then one should undergo diagnostic evaluation with an MRI or a multiphasic CT. Once again, a relatively simple follow-up test that's non-invasive. This is simply more imaging. It does not require biopsy as the next step. In those patients in whom ultrasound does not perform well, which can happen in some patients with either obesity or some patients with a lot of fat in the liver, then one can consider even doing a screening MRI or CT in those patients. But we need to have good quality imaging of the liver, both as a screening test, and then if one is to have an abnormal test, one needs higher resolution imaging as a diagnostic test at that time. Now, one of the main issues that sort of causes patients to be diagnosed at a later stage is the fact that HCC screening is underused in clinical practice. We heard about this during the talk before me in terms of HCC screening, unfortunately being used in a minority of at-risk patients. So when one takes a look at the studies that have been conducted over the last decade, we find overall only 1 in 4 patients with cirrhosis or chronic hepatitis B receive adequate screening prior to diagnosis. Once again, one of the main reasons that we see a large proportion of patients being diagnosed at late stages. When one takes a look at this from geographic location, we see lower screening use in the United States. We see higher screening use in Europe, but we still see over 1/2 of patients not receiving screening as they should. So this really is one of the main areas that we need to improve, in part by advocacy efforts by several of the organizations on this call today. And finally, my last slide here is that I talk about ultrasound and alpha-fetoprotein, but there's a lot of evaluations that are ongoing to take a look at many novel and emerging strategies for HCC screening, including either new blood tests that would be even easier to do, or even more intensive tests that would give us higher sensitivities or higher accuracy, including some MRI-based strategies. I'm not going to go through this in detail, but I think many of these appear very promising. And so I do expect to see even more options for HCC screening over the next several years. So in summary, I hope that I've been able to show you that HCC screening is important. It is supported by high-level data in chronic hepatitis B, as well as in patients with cirrhosis. The current standard, ultrasound and AFP, have suboptimal sensitivity for early-stage HCC and poor adherence, but these are good strategies that we can implement today. We know that we have many other strategies that are coming around that will even help further, such as abbreviated MRI and these biomarkers, these blood-based tests that I referenced at the end. And so we're going to see even improvements in this, but we need to do a job of implementing HCC screening at this time. And I think one of the exciting things is as we have multiple options available, we can strive for a model of precision screening, where we can actually define the best screening test for each individual patient. And I think by doing this, we will actually optimize HCC screening even further in the future. With that, thank you so much for the opportunity.
And thank you, Dr. Singhal, for the informative and detailed presentation. We wish you a good rest so that you can return to your clinical duties. Dr. Singhal will have to leave the webinar now, but if you do have questions, you can still log them through the question box. And if we're unable to answer them, we will get back to you in communication with Dr. Singhal. So later in this webinar, we will explore prevention and advocacy for liver cancer. But now we will hear from Ms. Lily Kushner-Wright, who works as a medical and scientific project coordinator at DICE. Lily holds a master's degree in molecular and cellular biology and has volunteered or worked in patient advocacy since her teenage years. At DICE, her main area of focus is liver cancer, and this year she has carried out an HCC liver cancer prevention and diagnosis survey. So today, Lily will present a summary of the preliminary results of this research project. Welcome, Lily.
Thank you, Fiona. Let me see.
So I will actually present highlights not just from this year's project, but I will also talk a bit about last year's project because the two tie together very nicely. So as you have already heard some of these alarming numbers, liver cancer is the 5th most frequent cancer and the 3rd most common cancer-related cause of death in worldwide and in Europe. In 2020, 87,000 Europeans were diagnosed with liver cancer and 78,000 sadly passed away in the same year, and these numbers are on the rise. And the most common form of liver cancer, hepatocellular carcinoma or HCC, is an often preventable disease, as you will hear throughout the upcoming talks. And there are several treatments that are associated with long-term survival when HCC is diagnosed early, as you heard. And sadly, despite this, the incidence and mortality of liver cancer continue to increase, which is a Europe-wide and global health concern that we all need to work together to tackle. And this is why DICE has carried out 2 research projects, because through a better understanding of the status quo in HCC prevention, diagnosis, and treatment availability, we can develop targeted efforts to reduce the impact of HCC. And our projects aim to scope the availability of HCC treatment across Europe last year and create a map highlighting the currently available treatments in each country. And this year, we mapped the landscape in HCC prevention and diagnosis within Europe. And we will also produce a similar map. And the methodology for our research projects was, first of all, many thanks to EASL, ELPA, ILCA, and ILCM, and several other organizations, including our member organizations, for their help, through which we then sought the input and experience of clinicians, patient organizations, and public health experts across Europe. We created online surveys which were distributed among these stakeholders over the period of 4 months, and carried out data analysis and constructed an interactive map, as I mentioned, where all countries that participated are clickable, and the table with the highlights of the data is accessible for each. And we also produced 2 concise reports that summarize the main advocacy points that arose from the projects, and I will talk to you a bit about these. And we are also producing translations of the reports to the languages of our member organizations. So first of all, I will tell you a bit about last year's project and the highlights from it. So we had a total of 223 participants from 27 EU member states. And some of the highlights include that, as you heard, the clinical practice guidelines from ESMO and EASL provide very clear recommendations on best practice care, which is defined by the Barcelona Clinic Liver Cancer BCLC staging system. However, not all participants were familiar with the ESMO and EASL guidelines, and 19 of the participating member states have own specific guidelines, but most participants, were not aware of these guidelines. And on average, the adherence to the guidelines falls between 50 and 75% only. Also, multidisciplinary treatment is not accessible to all liver cancer patients across the surveyed member states, even though multidisciplinary treatment is integral to cancer care management and is associated with improved survival rates. Furthermore, liver transplants in liver cancer patients are not regularly performed across all member states, and in most member states, transplant waiting time is over 6 months. And living donor liver transplants, which are a form of liver transplant where a piece of a healthy person's liver is taken and donated to someone who is in need, are not performed in 10 out of the 24 member states, even though this option would greatly improve transplant availability. And in 11 out of 24 member states, only some EMA-approved systemic therapies are accessible and fully reimbursed, while it would be crucial that all these therapies should be accessible and reimbursed to all patients. And alarmingly, quality of life, which is a critical aspect of patient outcomes, is in 22 out of 24 member states not investigated. Quality of life questionnaires are not used, only in clinical trials, if at all. And here is the link for the interactive map if anybody is interested. And from this year's research project, I would also like to share a few details. And if you would like to hear more about it in the future, DICE is hosting another event on the 24th of October, where I will share a bit more. So now I will just give you some key facts. So first of all, we had 222 people from 20 EU member states and 2 additional European countries participating. And some of the highlights include that, as you have heard, hepatitis B and C infections are well-known risk factors for developing HCC. And our results highlight that, on average, only half of the participating countries have a hepatitis B vaccination strategy that is extensive enough to facilitate reaching the WHO's goal of eliminating hepatitis by 2030. Furthermore, the prevalence of alcohol-associated and metabolic dysfunction-associated steatotic liver disease is increasing, as we heard, and these are also well-known risk factors for HCC. And only approximately half of the participating countries indicated that official organized efforts to prevent people from developing metabolic disease exist, while only 18 indicated that there are official organized efforts to control the accessibility of alcohol and the popularity of alcohol consumption. Furthermore, the awareness level of the general public about the risk factors and the signs of symptoms of HCC was, on average, perceived as poor by our participants. And the awareness level of primary care physicians about the same topics was also perceived as poor to moderate at best. And this is also a very important issue to tackle. In half of the participating countries, there is stigma around HBV and HCV, and the numbers are only slightly lower for liver disease in general and HCC, and this also highlights a very important issue that we need to address. And only in 15 out of the 22 participating countries is surveillance every 6 months in patients with liver cirrhosis is implemented. And as you heard from Dr. Singhal, this is the recommendation of all major clinical guidelines and greatly reduces liver cancer mortality. In about half of the participating countries, HCC is most commonly diagnosed at advanced or terminal disease stage, which is the result of the lack of surveillance. And this is something that we definitely need to address. So in conclusion, our results draw attention to inequalities between European countries and highlight several shortcomings that we need to together tackle. There is a need for more coordinated prevention efforts targeting viral and non-viral risk factors, and you will hear a bit more about this later during the webinar. And early diagnosis, as now I highlighted, and also the one speaking before me, is associated with better overall prognosis and patient outcomes. It is overall easy to infer who is at high risk of developing liver cancer, and screening groups of people who are at high risk is a robust method for reducing mortality. Ultrasound-based liver cancer surveillance every 6 months needs to be implemented in high-risk groups. Furthermore, the public awareness of liver cancer, based on our results as well, appears to be much lower than for other cancers, despite its significant burden. So increasing awareness about liver disease and liver cancer is key to tackling hurdles, for example, stigma. And the takeaway message is that liver cancer sadly remains one of the few cancers with increasing incidence and mortality. So all European countries must place liver cancer high on their agenda. And it is the responsibility for all stakeholders active in the field to collaboratively address the issues that include lack of effective prevention strategies, late diagnosis, and stigma. So we must work together to raise awareness about liver cancer and reduce its devastating impact. And this is why we are here today. Thank you.
Thank you, Lily, for that overview of this insightful project. We will now turn to the topic of patient advocacy. First, I welcome Mr. Milan Mišković from the European Liver Patient Association, ELPA. He will speak on liver cancer advocacy in Europe. Milan holds a master's degree in civil law and another in international patient advocacy management. He is the founder of the Liver Centre of Bitola in North Macedonia and represents North Macedonia in his membership with ELPA, where he currently serves as vice president and CEO and as a director. Milan is also president of the Alliance of Patients' Organizations in North Macedonia and a member of an advisory board project which addresses gaps in the prevention of HIV and other co-infections among people who inject drugs. Welcome, Milan.
Thank you very much, Fiona. It is a pleasure today to be among so distinguished guests and speakers who are trying to elevate liver cancer higher on every kind of agenda, I will say, from the political to the science. I will try to share my slides in the moment I find it. Okay. It's open? Super, excellent.
Good, thank you.
Thank you so much, Fiona, for the introduction. On the beginning, I will try briefly to inform you about the main values and vision of ELPA. Probably you know most of our stakeholders share the same vision and share goals. I will not keep my speech on most important things in the field of liver disease, but shortly in this slide is described the goal of ELPA. Also, our value, how you can see from these slides, we speak about our equality, respect for diversity. Now, what is most important, ELPA is one of the patient association who is really patient-driven. Also, what is very committed for ELPA, our goals to be somehow higher on the political agenda in Brussels. Why we like to elevate this, let's say, existing gaps in the moment which exist in the liver field to be improved in the next upcoming period. Also, the transparency, like one of the patient main core values is for ELPA in the same time. From this slide, you can see a lot of activities from the different members in ELPA, especially connected with Liver Cancer Month. This is activities done the previous year and before that. ELPA is very proud that in this moment, I'm speaking live from the European Parliament, where yesterday, for the second time, our pilot initiative, European Liver Screening Week, started in Brussels, together with enormous support and patronage of the President of the European Parliament, Roberta Metsola, who granted this patronage to this event to highlight the importance and the unmet needs of the liver community at European level. What we like to share is that also this European Liver Screening Week is going to be 5 days from yesterday, Monday, till Friday, all this week from 9 till 5 o'clock in front of the square on Esplanada. We are inviting all the deputies in the parliament and their employees to make easy screening of their liver, to understand the needs of the liver community and the easy way how in the 21st century, sometimes we can get a very fast information about your liver health. This is one of the main goals which we like to achieve with this European Liver Screening Week, which Also, it's connected with October Liver Cancer Month, where ELPA, together with you, like all stakeholders, trying to get attention from different, let's say, sides, from the science, from the policy decision makers, which was one of the most important things, because how we know the late 5 till 7 years, but for the first time in the history, in the hepatology, we have so many ongoing things about liver disease, especially particularly with liver cancer and their risk factors. How we can let's say, describe these pillars, what ELPA is doing. From this slide, you can see what ELPA is dedicated to do in the next period. Organization management is one of the most important things, because ELPA is based in Brussels, and this management trying more and effectively and efficiently to work with different stakeholders who are in the heart of Europe. Also, the members' engagement is one of the our core of work. Why? We like to encourage our members more and more on the national level, at the member states level, to work with different kind of stakeholders, which we usually call the boots on the ground, where ELPA try to connect the dots between the European, international, and national level, where these gaps and existing problems to cover somehow. Also, one of the most important pillars is the policy and advocacy work, which we are trying to do it in many different ways on different levels, especially on national and European level, where ELPA is connected with many different stakeholders, trying to elevate liver cancer and liver disease higher on the political agenda. Scientific engagement is one of the most important topics for us, like a patient community, because without scientific support and tools which are provided from the scientific side, we can do nothing. This is the reality, and the scientific community is one of the, let's say, communities which particularly try to provide more evidence-based materials and tools for the patient community to disseminate and to inform our main stakeholders who need to make a different kind of decision in the next period. This is somehow I try to describe the role of European Liver Patient Association on a European level. But what is crucial here, our work is not just connected with us and with our members. Our work is connected on multidisciplinary way, which we are showing today, this, let's say, approach through this initiative United Against Liver Cancer. And we are so grateful that we have a lot of possibilities together to do in the same time. And in the same time to catch the point from different perspectives, from early detection, prevention, awareness, and many other things. This is something which I think giving the space in the next period to improve the outcomes for the liver patients, especially in Europe, in the same time in the global scale. Because I mentioned the scientific community, from this slide you can notice that we have a lot of engagements and work done together with our main stakeholders, scientific community in Europe, in different projects. In the moment, we are participating in 20 medical research projects, which are more than 150 million euros just for liver research. We are directly or indirectly connected with the liver cancer or their risk factors. And what is very important in all of this research, the partners. How you can see in all of this consortium are more than 200 different partners on European and international level, which are giving completely a different picture from the past. This means that somehow the European institutions and the corporate industry, the patient association, academy, and research communities recognize the unmet needs to be resolved much faster than in the past. This is how we try from this, let's say, united approach to this consortium to valorize their impact in the next period and to change many things and many gaps who exist and barriers who exist in the moment at European level in the liver field. ELPA, what also is dedicated to do, somehow made it a different patient experts group. One of the patient experts group is for liver cancer, which is completely dedicated today. It's really my honor to tell you that I'm stepping in this group like a leader from today, which giving me a lot of let's say gratitude to my colleagues that I hope in the future working with you guys in this United Against Liver Cancer Action Initiative, which exists in the moment. With our contribution, we can change a lot of perspectives for our patients, particularly in Europe, and also a lot of knowledge which exists in a global level can be disseminated and also transferred to different levels among our members and at European level. Liver cancer advocacy in Europe usually.
Milan, I'm afraid I have to interrupt.
No problem.
We're quite tight on time, and I do see that you've got several slides left. Are there one or two that you'd like to skip to for your important highlights so that we don't run over time?
I will highlight the most important highlights, which is now in the moment, what is most important pillar for all of us here, for all stakeholders, which are present on today's webinar. It's European Beating Cancer Problem, which giving one of the best tools for us to change the future of the liver cancer. How you can see this approach, which ongoing this couple of years, giving completely different perspective how liver cancer can be involved in the different roadmaps. But we need crucial things which we need to overcome. And one of the most important things which I would like to mention is the liver cancer screening policy. That is one of the most important topic, how we like to let's say, change at European level if we like to achieve let's say bigger results in the next period. This is one of the things from my end. I hope so that many things are missing in our work. Thanks to you, are covering somehow on different ways, but ELPA in this moment is really dedicated on early detection and prevention for liver cancer.
Thank you so much, Milan. And my apologies that we had to rush you there. There is so much vital information to share, and I know it's great to have such a broad overview of ELPA's activities and some of the advocacy situation in Europe. Milan, would you mind removing your screen share while I introduce the next speaker, please? So we're going to stay on the topic of liver cancer advocacy, but move to the global perspective. I'm pleased to introduce Mr. Achim Kautz, who is representing the International Liver Cancer Movement, ILCM. Achim has a degree in communication sciences and a long-standing expertise in advocacy in the health sector. With over 100 peer-reviewed publications, Achim has a special interest in promoting policy discussion across different healthcare settings. Previously CEO of the German Liver Health Association and also a co-founder of ELPA and the World Hepatitis Alliance, Achim is a member of the World Health Organization National Strategy Planning Group. He's also a member of the German Ministry of Health Advisory Committee for Viral Hepatitis and a member of the Expert Committee of the Joint Committee in Germany. The floor is yours, Achim.
So thank you very much, Fiona, and it's a great pleasure to be here. And thank you to the organizers, but also to the participants of this webinar, because DICE, ILCA, EASL, and ELPA, you are change makers. And you are part of the global family of the global movement ILCM. And it's my pleasure really to talk today about how the global community look at liver cancer. The most important things we have heard already are the facts. Liver cancer is the sixth most common cancer worldwide, with nearly 900,000 new cases in 2022, and it's associated with a very high mortality. And we have heard there are treatment strategies existing with a good likelihood to cure, but when started in early stages. And the majority of patients are diagnosed in late stages, unfortunately, although the risk populations are well defined and diagnostic tools are available and affordable. That leads to the situation that in 2022, 760,000 patients died. And this is not acceptable. What the patients from all over the world are saying is, patients want to survive. They don't want to get liver cancer at all. And in case they have a liver condition, they want to be part of a surveillance program for liver cancer, as we have heard. And the patients want to get diagnosed early, so they could benefit from state-of-the-art treatments and have a chance to survive. So please use Liver Cancer Awareness Month here in October. Make a change. And please prioritize liver cancer in your national cancer strategies. And please prioritize liver cancer within the BICA plan. And make use of best practice examples from around the world. For example, Japan, Taiwan, or Egypt. And please use the support of the scientific organizations and the patient organizations who provide this webinar. I've talked now just 5 minutes plus, but please consider that within this 5 minutes, 10 people died on liver cancer. We need to change this. Thank you very much.
Thank you, Achim, for the global perspective and the pithy summary. Now I'll introduce our final speaker, Professor Shira Zelvasagi, representing the European Association for Study of the Liver, EASL. Professor Zelvasagi is a clinical dietitian, an epidemiologist, and a researcher in nutritional and lifestyle epidemiology, chronic diseases related to lifestyle and public health aspects. She holds a bachelor degree in nutrition sciences and a PhD in epidemiology and preventative medicine. She is a full professor at the School of Public Health, University of Haifa, Israel, and has written over 150 scientific publications. Professor Zelvasagi is a member of the Israeli National Committee for Nutrition, Gastroenterology and Liver Disease, and was also the founder of the Gastroenterology and Hepatology Dietitians Forum within the Israeli Dietitians Association. She is currently an EASL governing board member and public health counselor. Welcome, Shira.
Thank you so much for the introduction. I am honored to give this talk today, and I'm also happy for the opportunity to emphasize once more that liver cancer can be prevented. So let me tell you a little bit more about prevention of liver cancer. So a little bit facts that we know. We know that almost 30 million people in the European Union live with chronic liver disease. And between 1990 and 2019, there is a 70% increase in deaths due to primary liver cancer. This is quite amazing. And we know that the major risk factors are type 2 diabetes and obesity, which are associated with increased risk of liver cancer, partially because they are strongly related with metabolic dysfunction associated steatotic liver disease, MASLD, which is one of the leading causes of liver cancer. And that is why weight loss, dietary modification, and increased physical activity remain the mainstay of prevention of liver cancer. So some things in life we can control and some we can't. So there are risks for liver cancer we can control. This is increased age, male gender, and genetic predisposition. But there are many other risk factors we can control, which are related to lifestyle. So weight loss, regular physical activity, healthy diet like Mediterranean diet, coffee consumption, abstaining from alcohol consumption, and smoking cessation or avoidance can prevent liver cancer. And these are things we can control. To be more specific, what are the lifestyle modifications we all need to do to prevent liver cancer? So we need to eat more fish, more monounsaturated fatty acids, which are found, for example, in olive oil, omega-3 fatty acids found in fish and walnuts, eat more vegetables and fruits and fiber, have a plant-based diet with low amount of red and processed meat, which is called altogether the Mediterranean dietary pattern. You can have coffee if you want, it can be helpful, and again, physical activity and live a healthy lifestyle. What we should avoid as much as possible is obesity, type 2 diabetes, red and processed meat, a lot of saturated fat, unhealthy diet with a lot of animal fat. We need to avoid sugar and sugar-sweetened beverages, alcohol, smoking, and sedentary behavior. This is my take-home message for you, how to prevent liver cancer. And we know that one of the leading risk factors for liver cancer, as I said, is fatty liver disease or metabolic dysfunction-associated liver disease. And the amazing thing about this disease is that on the one hand, it's bad because it can progress to liver cancer even without a stage of cirrhosis. It can go directly to liver cancer, which is bad. But on the other hand, there is so much evidence showing that this disease is preventable and treatable if we keep a healthy lifestyle. So in every stage of the disease, just fatty liver, or even when the stage is beyond that of inflammation, NASH, MASH, fibrosis, we can have lifestyle modification that reverses the course of the disease. So a healthy diet, Mediterranean diet, weight reduction, these are the key ways to treat this disease and then prevent also liver cancer. Let me give you some example of the relationship between specific foods and liver cancer. So this is a huge cohort study of almost 100,000 women, and they were followed, and their dietary intake was tested. And you can see that those having at least 1 serving per day of sugar beverages have 70% increase in the risk of chronic liver disease mortality. And if you drink at least 1 sugar beverages a day, you have 85% increased risk of having liver cancer. So don't drink sugar beverages. Artificially flavored beverages were not related with liver cancer. It doesn't mean they're recommended, but water is the best, but they are better than sugar beverages. Coffee is protective. It has been shown in many studies that there is a dose-response association, as you can see on the left, between coffee consumption and prevention of liver cancer. And 2 cups of coffee per day can reduce by 30% the risk of having liver cancer. And altogether, when we look at a healthy lifestyle, which includes physical activity, healthy diet, good sleep, no alcohol, no smoking, how it can prevent cancer. So it can prevent many types of cancers, but also liver cancer. It can reduce the risk by 30% if you keep a healthy lifestyle. And there is a lot of importance between the combination, the harmful combination between obesity, type 2 diabetes, and alcohol consumption. So people who have obesity or type 2 diabetes, the risk of having liver cancer or severe liver disease is increased starting from a very low level of alcohol consumption. So even you can look at the blue lines, people who have obesity, you can see that even if they drink just 10 grams of alcohol per day, this is just 1 drink of alcohol per day, those who suffer from obesity already have very high risk of developing advanced liver disease and liver cancer. So people with obesity and type 2 diabetes should avoid as much as possible alcohol consumption, even low consumption. Smoking is related strongly with liver cancer. This is a summary of many large studies. It is related with increased risk of muscle and increased risk of fibrosis and increased risk of liver cancer. Current smokers and heavy smokers have the highest risk, but even former smokers have lower risk but still increased risk. So try to avoid smoking as much as possible. The prevention issue is so well evidence-based and so important that the recent EASL clinical practice guidelines for muscle devoted a chapter for prevention. And they clearly state with a strong recommendation that prevention of liver disease, advanced liver disease, and liver cancer is recommended through lifestyle modification. And there is a lot of data within these guidelines, which I recommend reading, about which exactly lifestyle modifications are needed for the treatment, prevention of mast cell, and prevention of liver cancer. And of course, patients need help with implementation. We need multidisciplinary care. We need structured lifestyle prevention intervention programs, and we need support from the community and the health system to be able to implement those lifestyle modifications. But we can't put all the responsibility on the population or on the patients. We need to change the environment. We need to make the environment more friendly for a healthy lifestyle. And so, for example, we need to use policy measures to help the population keep a healthy lifestyle. And that was tested in the HEPA Health study published by EASL. These are prediction models looking what would happen in Europe, in 3 countries in Europe, France, Netherlands, and Romania, if we implement policy measures to reduce alcohol consumption and sugar-sweetened beverages consumption through taxation. And we show that, that if we follow people with these policy measures up to 2030, we will reduce thousands of cases of liver cancer. In fact, we will reduce between 3 to 5% of the cases of liver disease and liver cancer in these 3 countries if we implement minimum unit pricing for alcohol and sugar-sweetened beverages taxation. This is really important. And there is a lot of place also to consider socioeconomic barriers. We need, when we provide recommendations to the patients and the population, we need to remember that people with low socioeconomic status have food insecurity. Food insecurity means not only hunger, it means that people cannot buy the healthy food they really need, and they are forced to buy cheap, low quality food, processed food, which leads to liver disease and liver cancer. So every time we provide recommendations, we need to be sensitive to socioeconomic inequities and food insecurity. EASL is doing a lot of advocacy in this field to prevent liver cancer. These are just a few examples of EASL policy statements for migrant health, which also addresses a lot of social inequities issues. EASL policy statement on reducing alcohol harms by policy, and of course, early screening of liver cancer detection and early treatment. You're all welcome to see those statements in the EASL website. The new EASL Lancet Commission decided to put a lot of effort about prevention. So instead of focusing on patients with advanced liver disease, we focus on prevention of liver disease, taking care, you can see the yellow color here, taking care and paying a lot of attention of socioeconomic inequities and the need to change the environment to make lifestyle modification easier for the population and the patients. And we have now medications for liver disease and for mast cell, but always the base of the pyramid is equity, policy, advocacy, and lifestyle modification. This is the base of every preventive and treatment approach in liver disease. If you want more information about liver disease prevention and treatment, you can find it in the EASL website, for examples in the materials published for the World Liver Day. You're welcome to look at it. There's a lot of materials also adjusted for the general public. And with that, thank you so much.
Thank you, Shira. And thank you to all our speakers. We are coming up to the hour, and we have had a few questions in, although we are very keen to stay on target. Some of these questions actually may be best answered if you are able to follow some of the social media campaigns from all of our organizations and some of the extra activities that we're running for this whole month of October. For example, one of the organizations has produced a series of podcasts that you can listen to. DICE is running another webinar at the end of the month to bookmark this Liver Cancer Awareness Month. There have been some questions about Lily's project, and in that webinar, there will be some much more detail given for those project results and where to go forward from that. And all of our organizations have shared quite a few ways to be involved for healthy living and changes of lifestyle tips, where you can post about this throughout the month on your own social media channels, but also look at the links and read the information to learn for yourself and find out for yourself how you can make a difference in what you do right now today, as well as thinking more about the big picture. So on behalf of organisations, we really want to thank all of our speakers, but also thank you who have attended and have joined and supported us in this. The recorded link for this webinar will be available in about 2 days' time, so do please check your email inboxes for that. I think it may also be shared throughout some of the social media posts as well. And to finish, we'd just like to remind you and close with the concept of this webinar. We are united against liver cancer, not only during this special awareness month of October, but united against liver cancer for the whole year. Thank you very much, and we look forward to seeing your involvement across our social media platforms. Bye-bye.